Good afternoon, everyone. I think we can start the talk now. We are now moving on from from the last talk itself. We are moving on from the just an initial understanding and overview of what is happening in hematology and what are the various approaches to basic hematologic problems. Last time, Dr. Swati gave a talk which went forward from that as to what happens when one of your patient has abnormal cells in the blood, and what's our approach to that? How do we diagnose it? Uh, so today, going beyond that, we will talk specifically about blood cancers and what are these cancers? What is the concept of diagnosis and treatment of blood cancers? So, broadly speaking, there are only three kinds of blood cancers, right? So there is leukemia, lymphoma, and myeloma. I call them LLM. It's easy to remember. So leukemia, lymphoma, myeloma. In leukemia, what we have essentially is there are cancer cells floating around in the blood. So if blood cancer cells are floating around in the blood, in the peripheral blood, or in the bone marrow, then we call it leukemia. However, if the cancer cells are largely restricted to lymph nodes, we call it lymphoma. Myeloma is a blood cancer of plasma cells. Okay. So this is the difference. Leukemia means cancer cells are in the blood or marrow. Lymphoma means cancer cells are in the lymph nodes. And myeloma is cancer of plasma cells. This is the frequency. So if somebody says, hey, how common is it? And quite often nowadays we hear general public saying that, cancers are increasing. And we are finding that more and more patients are getting diagnosed with cancer. More than an actual increase in the number of new cancer patients. Probably what is happening is previously a lot of our oncology patients, whether blood cancer or cervical cancer or GI cancer, whatever it was, they used to die without a diagnosis. They would present late, or they would only present to a doctor, a hospital, when they are terminally ill, and thus they would pass away without a proper diagnosis. However, what is happening now is most of our doctors, colleagues are pretty well aware. Plus, we have easy access to tests. It's very easy to get a blood count anywhere in any part of the country today, except maybe in remote tribal places. Of course, as previously discussed, we know the quality of testing may not be robust, but still, most of us have good access to some blood counts, CBC, etc. Most of us are pretty aware of when to refer a patient, whom to refer to. And the referring doctors like us, I mean, the doctors who get patients referred to, we have access to good diagnostics, good labs. We may not have labs within the city that we are working, but there are good nationalized labs. There is a network of lab, we've all heard of Lal Path and Metropolis, etc., etc. And they can pick up the sample practically from anywhere in the country. And thus today we understand that patients are diagnosed more frequently, and that gives us a sense that maybe cancers are increasing, but probably not. When it comes to LLM, leukemia, lymphoma, myeloma, there are about 40 new patients per lakh population per year. Now, this is an international statistic. We don't really have, comprehensive data from India. Yes, we have cancer registries, but these only collect data from about 15 to 20% of the population maximum, which means that more than 85% of cancers in India go unreported. Nobody really knows. So we are left to extrapolating the incidence in our country from international data. And fortunately for us, except in rare instances, the incidence of cancers are almost the same around the world, largely blood cancers at least. So if you extrapolate this to our population, we have over 5 lakh new patients with either leukemia, lymphoma, or myeloma per year, which means more than 1,500 new patients are there per day. So spread across the geography of this large country. And thus it becomes extremely important for us to have some core concepts of these diseases. So, what are these diseases? Uh, Essentially, what is supposed to happen is the bone marrow, which is the factory, has immature cells, right? These are the stem cells. They then become committed to progenitor cells. Then, I mean, the progenitor cells and the committed cell lineages. Then these committed cells should later on differentiate into neutrophils, eosinophils, B lymphocyte, T lymphocyte, plasma cells, right? So these are the end products of the bone marrow as a factory, end products of hematopoiesis. However, when this maturation does not happen, when from the hematopoietic stem cell all the way to the terminally differentiated cells, which are different WBCs essentially, right? So blood cancers are cancers of WBCs actually. So whether you have granulocytes, or you have lymphocytes, or your plasma cells, that differentiation is not happening. Somewhere in between, there is a problem in the genetics of the cells. Because of that, that cell is not able to mature, and it then just at an immature stage it starts multiplying. And if it multiplies in the marrow, it will pack up the marrow. If it multiplies in the lymph node, it will pack up the lymph node. And when that happens, this uncontrolled and unnecessary proliferation of immature cells, because they are immature, mind you, they cannot do their job. So, an immature cell, which is called as a blast, a hematopoietic cell, cannot provide immunity. So, an immature plasma cell cannot make good immunoglobulins, cannot make good antibodies. An immature myeloid cell, which is leading to AML, acute myeloid leukemia, cannot do what a neutrophil does, a terminally differentiated neutrophil does. So it cannot do
मम्मी
phagocytosis,
उन्हें मुंडे ने नहीं आना उन्हें नहीं आना आज
right? So the immature cells cannot do their job, and they are just proliferating in an uncontrolled manner, in an unnecessary manner, and thus they pack up the cell where the organ where they're proliferating. So if they're proliferating in the marrow, they pack up the marrow. If they're proliferating in the lymph node, they pack up the lymph node. And beyond that, they can also spill over to other organs. So they could spill over from the marrow to the blood. The lymphoma cells can spill over from the lymph node to the blood. Yeah, they can spill over and enlarge the liver and spleen. They can spill over and infiltrate other organs. So we get lymphoma in the brain. We can have lymphoma spreading beyond lymph nodes and infiltrating soft tissues. It can infiltrate the ovaries, testes, it can infiltrate the breasts, or even skin and subcutaneous tissue. So as these cells multiply, not only do they pack up their own organ, but they spill over and can infiltrate other organs. Just a minute, let me. Yeah. Myeloma cells similarly can infiltrate the bones. They can infiltrate the bones and lead to what are called as lytic lesions. So you see, what is the difference between a plasma cell growing in the marrow, whereas a plasma cell damaging the bone? Okay. So a plasma cell, which is now immature, has become cancerous, has become a myeloma cell. It is multiplying and packing up the marrow, and at the same time, it is causing osteolysis. It is causing breakdown of the bone around it, leading to holes in the bone. Holes in the bone are called lytic lesions, and these holes can become so large that it leads to fractures. So this is how hematologic malignancies can affect the body. Now, if you get a patient, typically, leukemia, where because the bad cells, the cancer cells are packing up the marrow. So, because the bad cells are packing up the marrow, there is no space for the good cells. There is no space for the good cells to multiply. So, your RBCs can't multiply, hemoglobin goes down. Your good WBCs can't multiply, immunity goes down. Your platelets can't multiply, platelet count goes down, and there can be bleeding. And then in the peripheral blood, or because there are, low hemoglobin, low or high WBCs, low platelets, because of that, you say, hey, I'm going to do a bone marrow. And you do a marrow, or your pathologist calls and says, no, 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 there are some atypical cells in the blood. Go ahead and do a marrow. So you've done a marrow. Similarly, you have a patient with lymph node enlargement, and you think maybe it's reactive. So you give 2 weeks of antibiotic therapy. Yeah. And you say maybe this is reactive lymphadenopathy. I'm going to give antibiotics, and in 2 weeks the lymph nodes don't come down, or new lymph nodes start forming. And you say, no, no, something is wrong. This can be tuberculosis, this can be lymphoma. I have to biopsy the lymph node, right? When you actually send the marrow or the blood or the lymph node to your diagnostic lab, to your pathology friends, how do they actually diagnose blood cancer? So, first of all, what they do is if it's a blood or bone marrow, they'll smear it on a glass slide and look under the microscope. If it's a lymph node, they will, they will process the tissue, and using a microtome, thin slices of the lymph nodes are made, and they are layered on a glass slide and put under the microscope. And then our pathology friends will look at the cells, marrow cells, blood cells, lymph node cells, and say, hey, how are these cells looking? Are they normal? Are they abnormal? What is the size? What is the nucleus like? What is the cytoplasm like? How are they looking to me? And it was almost 50 years ago that people started saying, you can differentiate cells just by looking at it. And what are the different kinds of cells? And that classification of blood cancer has evolved over the last 50 years. Initially, all that pathologists could do, or even oncologists could do, is look at the cell, right? And try to distinguish, is it a leukemia? Is it a lymphoma? Is it a myeloma? If it is a leukemia, what is the type? Is it lymphoid? Is it myeloid? What's happening? And all of this was based on how the pathologist, how well the pathologist was trained, and how did the cell look with basic stains. Basic stains, eosin and hematoxylin and other Romanowski stains, which we have spoken of in previous talks. How do they look? Basic staining, right? Size, etc. Eventually, it was found out that not just the basic staining, there are other chemicals that you can put on the slide. Yeah. And this chemicals will go and bind to the cell. Every chemical, goes and binds to different parts of the cell, and it gives a different color. And because these chemicals are going and binding to the cell, it is called as cytochemistry. Cyto meaning cell. So cytochemistry. And after a lot of research, experimentation, etc., there are, today three kinds of cytochemical staining that we use. Three. Yeah, three can be used. Of course, there are many, many more, but today we understand these three are enough for a lot of our work. Yeah. So one of them is SBB, Sudan black bee. Second one is actually a combo of cells. It is called as the double estrase, DSE staining, and so on and so forth. So once they have done basic staining and looked under the microscope, your pathologist may say, why don't let me put some more chemicals and see how does the cell look. With all of this, we had this classification called as FAB, and I'm going to give you the example of how this morphology can be used to diagnose different types of AML, acute myeloid leukemia, or ALL, acute lymphoid leukemia. Yeah. So depending on how much has the cell matured from a stem cell like morphology to a mature cell, where is the maturation stopping, at what level? Based on that, AML myeloid leukemia was divided from M0 to M7. And this is fascinating because in M0 the cells look just like stem cells almost. You can't make out, is it myeloid, is it lymphoid, what's happening. Most of the cells do not pick up your cytochemical other stains that you're putting in. Less than 3% of the cells are well differentiated. There is nothing such as an OR rod, and I'll tell you what is an OR rod, which will help us understand, is this really myeloid, lymphoid, what's happening? And that was called as M0, saying, hey, no maturity, very immature type cells. Then there is M1. M1, we start seeing that, okay, now at least more than 3% of the blasts, the cancer cells, the mature cells are now picking up your cytochemical staining, that is myeloperoxidase or SBB, right? And maybe now we have started seeing what is an OR rod. You see this OR rod. Yeah. Now it's important to notice, if you look at a cell, we compare the size of the cell with the size of a lymphocyte, a small normal lymphocyte. So the pathologist will look at various fields, or when I look at a marrow, I look at various fields and try to find a field where I have a cancer cell next to a normal lymphocyte. And I know the size of the lymphocyte, so I can say, is this a large cell? It is probably so many microns, etc. So based on the size of small lymphocyte, or if you don't have, maybe you can look at, compare with the RBC size and say, hey, how big is this? How is the nucleus? What is the shape? What is the maturation of the nucleus? What about the cytoplasm? Am I seeing any granules in the cytoplasm? These dots. And sometimes these granules will join to each other and form a rod, which is called as OR rod, AUER, OR rod. OR rod is seen only and only in AML, acute myeloid leukemia. So if there is an OR rod, we say, hey, this is AML. Very, very, very rarely will it be seen in any other disease. Okay. So OR rod is in AML. And we also, of course, look at how much is the cytoplasm. Is there a lot of cytoplasm or very little cytoplasm, etc., etc. As more maturation happens, means I am seeing that, now I am seeing multiple OR rods. We start calling it AML M2, and more and more cells become positive by cytochemistry. We then reach AML M3. Now you see, we have now reached a stage, AML M0, M1, M2, which were largely we can't make out. But from M3, we can make out that the maturation has reached a level where these now are resembling promyelocytes, or they're resembling monocytes, or they're resembling erythroid precursors. So now there is some differentiation happening. There is some maturation. It is not fully mature to a neutrophil stage, but it has reached a level where I can start suspecting. That's where AML M3 starts. Now, this is a very, 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 very important diagnosis. AML M3, also called acute promyelocytic leukemia, APL, promyelocytic, is extremely curable, very, very curable. 80 to 90% of patients can be cured permanently. Can you imagine blood cancer with 80-90% chance of cure? Right? Most important thing. Second, this blood cancer is caused by a particular genomic abnormality, mutation in the hematopoietic stem cell. There's a particular mutation, and this mutation has targeted therapy. So you don't even need chemo. You don't even need chemotherapy. You can just give targeted therapy and avoid complications. Second important point. Third important point, these patients get DIC, disseminated intravascular coagulation. And patients actually die of DIC. So they die of bleeding. And in the first 2, 3 weeks, if we can control the coagulation, if we can manage the DIC by transfusing FFP, cryoprecipitate, and platelets, then chances of cure are amazing. So understanding, yes, AML, is it M3? So in AML, acute myeloid leukemia, you have M3 and you have everything else on the other side. Everything else needs chemotherapy. M3 probably may not need chemo. Most of the patients don't need chemo. Great chance of cure. And they can die very quickly because of bleeding, right? So how do we know this is M3? This is a morphologic diagnosis. The cells have multiple OR rods. You see, this cell has so many OR rods. This cell has another OR rod. This one has an OR rod. Plus, you see this cell, there are OR rods, they are all parallel to each other. So the granules are sticking to each other, making a rod, and multiple rods are parallel to each other, right? They're like a bundle of sticks. A bundle of sticks. Remember when you were small, we used to pick up sticks. And when you have sticks together and you bundle them, that is called as a faggot. So this is called as a faggot cell, because in this cell you're seeing multiple OR rods bundled to each other. First. Second, the nucleus is bilobed. You see this? There are two lobes to the nucleus. This is an abnormal promyelocyte. Yeah. And third, there are a lot of granules. And these granules are released in the blood and they cause DIC. Okay. So if a pathologist calls me and says, Sachin, there are blasts, there are immature cells in the blood or the marrow, and I'm seeing faggot cells, I'm seeing bilobe nucleus, I'll say AML M3. Great chance of cure. Okay. Of course, some M3 patients are a bit different. They have different mutations and they don't have so many granules. They are called hypogranular variant and they are treated like other AML. They are not treated with targeted therapy. And in them, again, the prognosis is not great. Then we have M4, where now the blasts have started looking a bit like monocytes. You see, this is cytochemistry. You see, this is cytochemistry. And this is how different stains can give different color. So in M4 and M5, we see that the blast nucleus has started looking like monocyte. In M6, they look like erythroid precursors, not RBCs, not RBCs. The erythroid precursors in the marrow which mature to give RBCs. They're looking like erythroid precursors. Okay. And M7, where the blasts, the cancer cells look like megakaryocyte precursors. Megakaryocyte. Yeah. Again, not platelets, the megakaryocyte, which is the immature cell that gives rise to platelets, right? So we have M0 to M1, 2, 3, 4, 5, 6, 7. This was the classification used for a long, long time. And the correlate for ALL, acute lymphoid or lymphoblastic, so that's myeloid leukemia and lymphoid leukemia. Now, mind you, I'm only talking of acute leukemias today because we are not talking of chronic leukemias. CML, chronic myeloid, CLL, chronic lymphoid leukemias are different diseases. They are not usually life-threatening. They are treated in a different manner. We are not talking about that. We're talking of acute life-threatening diseases. So AML, ALL, acute myeloid, acute lymphoid leukemia. So the FAB correlate of ALL was called L1 blast, L2 blast, L3 blast, depending on the size. And today we don't really use this. This is an old classification. The ALL FAB is not used. Only thing that is important is ALL L3, this one. You see these bubbles kind of things in the cytoplasm. Yeah, they're called vacuoles. And if a pathologist sees this, it's probably Burkitt lymphoma, very aggressive lymphoma, leukemia, right? But for the large part, we don't use FAB in ALL diagnosis anymore. Why don't we say, M1, M2, my pathologist friend has looked at it, it is saying AML. Why do we need to do more tests? Isn't morphology enough? Not really, because hematology, hematopathology, these are new specialties. We don't have too many people who are trained, right? For example, today, almost all of us can report an ECG, all of us can report a chest X-ray, etc. But not many people can report peripheral smear, marrow, lymph node biopsy, etc. properly. So we don't have people who can really train, differentiate between different things. Also, morphology, that means how does the cell look? Very difficult to implement in the community. What I feel might be M1, another hematologist or pathologist may say, no, 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 this is M2. So there is an inter-observer variation. We don't really have objective means of using FAB, right? It's a lot to do about my knowledge, my experience, and somebody else may say it's something else. What I call L1 blast, somebody may say L2. And except M3, it doesn't really help in prognosticating. So if somebody asks me, Sachin, my uncle has AML M1, what do you think is the prognosis? Is it different from M4, M5? Well, I don't really know. So FAB is not great in prognostication. So why are we still talking about morphology? Because one, I need to know, yes, there are atypical cells. My pathologist has seen and said, this is not normal, this is atypical. I need to know, is there an OR rod? Then I know it's AML, the treatment is different, prognosis is different. It is not ALL. It is not lymphoma. It is not myeloma. OR rod means AML and AML only. I also want to know, okay, so that's the OR rod. I also want to know if it is AML M3 because M3, acute promyelocytic, like I told you, can suddenly die of intracranial hemorrhage. So the moment my pathology friend calls me and say, I'm seeing faggot cells, maybe M3, I immediately send PTA, PTT, fibrinogen, platelet count. I'll get FFP at night and transfuse because the patient can anytime die of bleeding because of DIC, right? So I only need these three things. And then if these two are not there, if OR rods and faggot cells are not there, but my pathologist is saying there are atypical cells, then I'm going to actually see what do the cells show on flow cytometry. That's the next step, flow cytometry. So what is this flow cytometry? Flow cytometry is a technique where when we send the patient's blood or marrow, what now we are getting into molecular diagnostics. We are going beyond basic pathology into molecular diagnostics. Our pathology friends, what they will do is they will take the blood or marrow and they'll put it in a tube. This tube has a substance called ficol. Ficol. Now, this ficol is a very thick, viscous kind of a substance. Okay, so when they put this bone marrow or blood on the ficol and then put this tube in a centrifuge, we have all seen centrifuges, right? When we put it in a centrifuge, the cells which will be pushed down through the ficol. Okay, they'll be pushed down through the ficol. And when they push down, because the ficol is a thick viscous substance, all the cells can't go through, so they are separated. The cells get separated. The RBCs go to the bottom. The WBCs are stuck above the ficol. They can't go through the ficol, so your WBCs are stuck here and plasma on top. Then you can use a pipette and suck out just the WBCs. All right, you can suck out just the WBCs. These WBCs are then sucked out by a pipette, put in other test tubes, right? They're diluted in other test tubes. And in that test tube, we put antibodies to various antibodies. So there are panels. So typically a molecular lab, flow cytometry lab will put, anti-CD45, anti-CD13, 33. We have all read this in pathology or during our entrance exams. So antibodies to various proteins on the cell surface. There are proteins on the cell surface or nucleus or cytoplasm. Antibodies, monoclonal antibodies are made, and those antibodies are put in these tubes. So if a cell has CD13, that antibody will stick to it. And that antibody is fluorescent. It is fluorescent. It will give a color. Okay. So you take out the mononuclear cell, that is the WBCs, put it in multiple test tubes. You put different antibodies in those test tubes, and then you put those tubes here in this machine. This machine is called as a flow cytometer. It's a fascinating piece of technology. What the flow cytometer does is, this is actually very similar to what we saw the cell counter doing, right? The Coulter principle. That means it will suck in the blood, I mean the cells, and the cells are coated with the antibody is attached to them, and these cells will flow in a single line. Single line means one cell after the other. They will go in a single file, and there is a laser which is put on these cells, right? This laser will, to some extent, it will go through the cell. To some extent, it will go through the cell, but the nucleus will not allow it to go properly. It will scatter. This is called as forward scatter. Forward scatter. So the laser which is going cannot go straight. It will be scattered by the nucleus. The granules which are there in the cytoplasm, they will scatter the laser on the side. This is called as side scatter. So forward scatter, side scatter, depending on the nucleus and the granules. And there will be detectors which will detect how much laser is getting scattered forward and how much on the side. Plus, what happens is the laser is of a particular frequency. Now you see this cell has these antibodies sticking to the surface. Can you see that? The cell has some antibodies, and depending on the frequency of the laser, it will give out, the antibody is fluorescent, I told you, it will give out a different color. It will give a different color, and these colors are again detected by other detectors. So in a flow cytometer, what happens is the cells go in a single file. We look at forward scatter, side scatter. We look at the different colors based on which antibody is sticking, right? Which antibody is sticking, and that gives us this. This is called as a scattergram. Scattergram. Now we know that lymphocytes are small, and they do not have too much side scatter. So the cells here, see, SSC, side scatter, FSC, forward scatter. So side scatter is very less, must be lymphocyte, right? Side scatter is very high. That means there are a lot of granules in the cytoplasm. Side scatter is very high. Granules, so must be granulocyte, must be a neutrophil. That is how, using flow cytometry, we figure out which are the cells. Then what happens is our pathology friends and the flow cytometry technician, they will say, all right, I am interested in, say, these cells. Okay. Low side scatter, blah, 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 CD45. I am interested in these cells. Now, in these cells, I want to see whether they have CD13, whether the cell has CD13 protein, which means the anti-CD13 antibody is sticking to it. So does it express CD13, CD33, CD41, etc., etc. And based on this, now you see here the cell, okay, it is high in CD41. If CD41 was low, all the cells would be here. So in this patient sample, there are many cells which have CD41 high. You see, this is the x-axis and y-axis. So more cells means it will come here. See, CD61 high, right? If it was low, it would have been here. So depending on which proteins are expressed, we then compare again, go back to the morphology and say, yeah, this looks like a megakaryoblast AML-M7. Okay, so I look at the morphology, I look at the protein expression by flow cytometry, and not just the eye, but we get an objective measure by flow cytometry. Is this protein expressed? Is it high expression, low expression? What is the side scatter, forward scatter, etc., etc.? And we combine all of this, and then we make a diagnosis. Now, flow cytometry based diagnosis. So just morphology, FAB, then add flow cytometry, protein expression, is been there for about 30 years now, right? And in the last 30 years, we have realized that even by flow cytometry, if I get a perfect diagnosis. When I actually try to treat 500 patients, some of them will get cured, some of them will not respond to chemo at all, some of them will respond but have an early relapse, some will respond and have a late relapse. So, how do I figure out which patient should get strong treatment, which patient should get mild treatment, which patient has a high risk of relapse? And that is where genomics came in play. In the last 30 years, with research by thousands of doctors and pathologists and researchers and molecular biologists, we now understand that even within AML and ALL, different patients have different genetic mutation. Now, mind you, this genetic mutation is not in the whole body. This is not the inherited genetic DNA that I get from my father and mother. No, this is the genetics of the cancer cell. So when we say cancer genomics, we are looking at genetics of the cancer cell. And we slowly realized now this is what we learned in AML. When I joined hematology 20 years ago, I was told that AML, if the cancer cell, the chromosome, the DNA has this translocation, so translocation of chromosome 8 and chromosome 21, if they are translocated, then it's a favorable genotype. Favorable means these patients will usually not relapse. Okay. So see, genomic mistakes, errors can be favorable and unfavorable. Let me give you an example. See, a cancer cell is like a terrorist. Cancer cell is like a terrorist. And like a terrorist will multiply unnecessarily, one terrorist will become 2 to 4 to 16 to 100 to 500 to 1000. Similarly, one cancer cell will multiply and make copies, make clones of itself. So one cancer cell will become 2 and 4 and 16 and 100 and 1000 and lakhs. So just like a terrorist multiply, the cancer cell creates clones. Okay. It is multiplying unnecessarily. It is multiplying uncontrollably, right? It is multiplying and not allowing other cells to do it their own job. So cancer cell will multiply and pack up the bone marrow or lymph node, and it will not allow normal hemoglobin to be produced, right? Similarly, the terrorist will multiply and not allow the normal villagers and city people to do their job. They'll harm others. Cancer cell can divide and infiltrate other organs. Terrorists can multiply and travel to other cities. They are the same. They are the same. Okay. The cancer cell has a mutation in the DNA. The terrorist has a messed up brain. The terrorist has a messed up brain. But even within that, there are some terrorists who are not that bad. You can still take them to court, put them in jail, and rehabilitate them, bring them into society. Some terrorists can be rehabilitated. The damage to their psychology is not very bad. Similarly, some cancer cells may have mutations which are not very bad. They can be treated with just chemo, right? The chance that this cancer cell will again, relapse is low. Similarly, there are some terrorists, once they're rehabilitated, they will not go back to terrorism again. They may marry, have a child, do a good job, and all that. But there are some terrorists who are completely messed up. You cannot rehabilitate them. It is not possible. Just not possible. Okay. Similarly, there are some cancer cells which have very bad mutations. So there could be TP53 mutation, translocation 69. These are all bad mutations. Okay. These cancer cells, if you give chemo, if you give chemo, some will die, some will hide, and tomorrow they will grow back and create a relapse. Similarly, there are some terrorists you send in the military. You send in the military, they will kill majority, but some of the bad terrorists will hide. And when the military goes, they will again multiply and terrorism will come back. So the question is, how do we cure cancer cells with bad mutations? How do we manage horrible terrorists? Because they will hide. The only way to handle them because they will hide and again multiply after 2 months or 2 years. After 2 years, military is not there. So, how do you prevent this? You have to change the police. You have to change the police. Remember, first time this terrorist, one terrorist could become 5,000 terrorists because the local police failed to catch them in the beginning. They failed to identify the first five terrorists and so they became 5,000. The police has failed. So here, not only the army action, but you have to change the police so that new police, maybe the new police can identify if this horrible terrorist starts multiplying again. Similarly, for blood cancers, you have to change the immunity. You have to change the WBCs. The WBCs are the police of our body. How do we change it? We do a stem cell transplant. We do a bone marrow transplant. I have a patient who has a bad leukemia, whose leukemia has bad mutations. I know there is a very high risk of relapse. I will take another person. I'll take that person's stem cells and put into my patient. Okay? I'll take this person's stem cells, put into my patient. I'll, of course, give chemo to kill off the cancer as minimum as possible. Then I'll take another person's stem cells and put, and I'll hope that these new stem cells will go in and multiply and make a new marrow and a new WBCs, new immunity. So tomorrow, if some cancer cells again grow back, my new immunity will be able to identify them and kill them. That is called as graft. Graft means new bone marrow graft, new stem cell graft. Graft versus leukemia effect. So my new stem cells, new immunity, the graft in the stem cell graft will fight leukemia. We will go into greater details of this in the talk about bone marrow transplant. But this is the core concept. We use genomics to understand who has a high risk of relapse. We also use genomics to understand if there is a targeted therapy. For example, you see this T922 translocation between chromosome 9 and chromosome 22. The gene is BCR-ABL. That means BCR gene from one chromosome, ABL gene from another chromosome have now come close to each other because the chromosomes have broken and they are translocated, attached to each other. So this BCR-ABL mutation, there is a targeted therapy. There's a silver bullet. And you all know this. We have all gotten WhatsApp forwards. Cancer is curable. There is one treatment, one medicine called imatinib. It is available free. That imatinib tablet is targeted therapy. So genomics tells me not only which patient has bad mutations, the genomics also tells me, hey, maybe this mutation has a targeted therapy. And if I use this targeted therapy with chemo, maybe I have a better chance of cure. Okay. So this is how what we have learned in cancer in the last 30 years in terms of genomics. And the more research is done, we realize there are so many different types of mutations. So many, hundreds of mutations are now known. Some mutations we know how do they affect the prognosis? Is there targeted therapy? There are many new mutations which are discovered, which we don't know how to use them in patient treatment. Okay. Nevertheless, the most recent classification for blood cancers is the fifth edition of the WHO classification. Okay. And in this, we combine morphology, flow cytometry, and genomics. We combine and put everything together and we give one final diagnosis. And we first see, okay, AML, acute myeloid leukemia, okay, fine. Which is the mutation? So many mutations. We know this has a good prognosis. PML RARA is AML M3 mutation, acute promyelocytic leukemia. This has a great prognosis. But we also know that if there is TP53, it has a bad prognosis. KMT2A, bad prognosis. So I will give a diagnosis to my patient. You have acute myeloid leukemia with KMT2A genomic mutation, cancer genomics. So this tells me this is a very bad cancer. Chances of cure with just chemotherapy are very low. And in those patients, we don't have mutation, we use the FAB. Morphology flow cytometry, we say, okay, you have AML M0, M1, M2, M3, M4. But as much as possible, we try to identify the mutation that gives us prognostication. So, how we practically put this together? Atypical cells on peripheral blood, marrow, etc. You're suspecting something, you do a bone marrow exam. Our pathology friends look under the microscope at the bone marrow, aspirate. How do the cells look? Or rods, blah, 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 whatever I told you, AML M3. Uh, we will also send for flow. Every patient needs flow cytometry. Okay. We'll look at the protein expression. We'll confirm, yes, this is AML, ALL, whatever. We also send for genomics for all patients. Has to be done. And we put all of this together and say what actually is happening. Okay. So atypical cells or rods, AML M3, not there, anyways flow, AML or ALL, add the genomics, and as per WHO fifth edition, figure out what exactly is the kind of leukemia, lymphoma, whatever it is. Once the diagnosis is reached, we are planning treatment. Okay. And when we planning treatment, we again think, hey, is there a mutation? If yes, is there targeted therapy? Because targeted therapy has best chance of success. And many times it's very cheap because we have generic targeted therapy in India, right? You don't always have to buy the original. If generic is available, it's cheaper than chemo. And side effects are less because it is targeted to cancer cell. It does not got side effects around the body. Like chemotherapy causes side effects around the body. So we try to see, is there targeted therapy? Is there the PML RARA mutation, that is AML M3, the APL mutation? Is there BCR ABL mutation, that is Philadelphia chromosome? If it is there, add targeted therapy to your chemo. Okay. No targetable mutation, just give standard chemo for the first month. 1 month later, let us see how much have the cancer cells gone down. How much have the cancer cells gone down? If the cancer cells have gone down below 5%, we say, okay, complete remission. Okay. But at this point, we don't just depend on, again, morphology. After 1 month, first cycle of chemo, we repeat bone marrow and we send it for flow cytometry. Flow cytometry will tell us what percentage of cells are exactly there. Even morphology, we can count 5%, 10%, 22%. Flow cytometry will tell us exact. There are 20% cells, or 18%, or 5%, or 2%, or less than 0.001%. Remember, flow cytometry is very sensitive. If flow cytometry tell us there are less than 0.001%, that means even by the best of technique, there is no residual disease. You can't see any cancer cell. Within 1 month of chemo, you can't detect cancer cell by flow cytometry. Even minimal residual disease is not there. That is MRD, minimal residual disease negative. So you understand, this is a patient whom we diagnose, we give first cycle chemo, 1 month later. Even by flow cytometry, I can't identify cancer cell. Does it mean that cancer cells have died? No, boss. See, flow cytometry and all that is sensitivity, we know. Sensitivity is 1 in 10,000 cells probably. Okay. What if there are less cells? There must be other cells, and we know there are other cells. However, this patient within 1 month of chemo, with or without targeted therapy, MRD negative, minimal residual disease negative. Even by flow cytometry, we can't identify. And then we go back to the mutation report. The mutation report is good. You have an excellent chance of cure. Good risk disease. Just continue 3-4 months of chemo and you'll be okay. Bone marrow transplant, stem cell transplant is not required. Okay. However, there'll also be another group of patients where after 1 month of chemo, you will detect some cancer cells. Flow cytometry will say, no, no, there are 2% cancer cells are seen, or 10% seen, 20% seen. So it is MRD positive. There are still cancer cells remaining. Or maybe the mutations you have seen, no, no, this is TP53 mutation, bad mutation. Okay, bad mutation. These patients, yes, they are poor, they have poor risk disease. You give them chemo and you follow it with a allogenic stem cell transplant. Allo means you take another human being, another donor's stem cells, and change the bone marrow, change the immunity, because this patient has a very, very high risk of relapse. And you need new immunity, new WBCs to identify and kill the cancer cells if they grow back later. So this is leukemia, AML, ALL. I told you acute myeloid, acute lymphoid. We are not looking at chronic leukemias. What about lymphoma, myeloma? Well, lymphoma is very simple. Instead of bone marrow, we send a lymph node biopsy. And pathology will look at the morphology of the cells in the lymph node. And instead of flow cytometry, they will put immunohistochemistry, antibodies on the glass slide. Immunohistochemistry, tissue. On the tissue, they'll put these antibodies, anti-CD, whatever, CD4, CD5, 8, and all that. So instead of flow cytometry, we use immunohistochemistry. Generally, for lymphoma, transplant is not required. Chemotherapy is enough. For myeloma, blood cancer, bone marrow, you will look at the morphology of plasma cells because it's a plasma cell cancer. Again, we can do flow cytometry or antibodies on the slide, immunohistochemistry. We also do serologic tests in myeloma. So we do protein electrophoresis because, the myeloma cancer cells, plasma cells, cancerous plasma cells will secrete an abnormal antibody, abnormal monoclonal antibody. So M band, M for monoclonal. So we can find that out by electrophoresis of the proteins in the serum. So serum protein electrophoresis and serum free light chain assay. So we use these, and all myeloma patients who are less than 65 should get a stem cell transplant, bone marrow transplant, but with their own stem cells, autologous, not allogenic. We are not trying to change their immunity. And we'll again come to this in the next BMT class, right? So summary, diagnosis needs morphology, that is microscopic examination, plus flow cytometry or immunohistochemistry, plus genomics. Everybody needs chemo. Give targeted therapy if available, and stem cell transplant for those patients who have a high risk of relapse. Thank you so much. Be happy to take questions.
Any
Sir, I have a
questions?
question.
Yeah, go ahead.
So the genomic study, what you explained in this leukemia and lymphoma, is it the same kind of genomics we do for other cancers also?
Yeah. So genomics essentially, look, there are 4 types of genomic studies if you actually boil it down. So I have put it here in a, I'm trying to find yeah. So you do karyotype, FISH, PCR, or next generation sequencing. It's exactly the same.
So that means if the genomics are negative, we can't able to identify any particular genetics sequence changes, then the response is good. That is a final impression.
No. Response is by flow cytometry or MRD. Genomics are the original genomics, and that tells us risk of relapse, the prognostication. For response, we do flow cytometry, etc. Pathology test, what I told you, MRD testing. We can also do MRD by flow cytometry or NGS. They're two different. Both have to be good. Okay. So both flow cytometry and the response and the mutation both have to be good to say good risk disease, only chemo is required. Okay. If any one of these is bad, either there is residual disease after first month or mutation is bad, then it's a poor risk disease and needs a transplant.
Excuse me, sir. My question is, can you show some light on difference between leukemia and myeloma, as both of them are involving the bone marrow? And
So leukemia is, myeloid or lymphoid, and the other plasma cells. Myeloma is cancer of plasma cells. They're cancers of different types of cells.
okay, sir. So the investigation that we are doing is different in both of them. Like one in myeloma, we are doing this protein electrophoresis and immunohistochemistry, whereas in leukemia, we are looking for the morphology and cytochemical morphology and other things.
See, in
What?
leukemia and in myeloma, the cancer cells are in the bone marrow. We are going to take the bone marrow sample, do morphology and whatever. In addition to this, in myeloma, we will do the serologic test. Those are the additional tests for myeloma.
After morphology, after doing the morphology.
We do them parallelly. Yeah. If we are have a
Okay.
high suspicion for a myeloma, we will do the marrow morphology, flow cytometry, and serologic test together, because everybody will not have everything, right?
Okay, sir.
See, the
Yes.
plasma cells, we have so many bones in the body. Plasma cells may not be uniformly spread everywhere in the body. They may have clumps of plasma cell. Now, I put my needle at bone marrow needle at one place to take a biopsy, right? If there are less number of plasma cells here, I may miss the diagnosis. So we put all the information together, the marrow, the immunohistochemistry, flow cytometry, and the serologic tests to say somebody has a myeloma or they don't have. Myeloma
Okay.
diagnosis is generally more difficult than leukemia diagnosis, because leukemia spreads cells are spread equally around the marrow, whereas myeloma cells may be present as clusters across the marrow, and we may miss the diagnosis.
And clinically, how do we suspect, sir? In leukemia, usually we see the WBC counts are on higher side
Or lower
uh,
side. Hmm.
or lower side. But whereas in myeloma, how where do we suspect myeloma? That is
Very
the
good
question.
question. So we have a separate talk on myeloma. Myeloma diagnosis, I told you, is a bit difficult. In myeloma, we have what is called as CRAB, C-R-A-B, CRAB, crabs, seafood. So C is calcium.
Yes.
So they may present with hypercalcemia. R is renal failure. They may present with high creatinine. A means anemia and B means bone. So in myeloma, CRAB is what generally points to a diagnosis. Hypercalcemia, renal failure, anemia, and fractures or lytic lesions on X-ray. Bone.
Okay, sir.
But that's a separate talk. We will have that. Don't worry.
Thank you, sir.
Sir, we have few questions in the chat box as well, sir.
Okay. Let me just have a look. Yeah. So Kingsley has said if someone has M1, can they know? They are different cancers. M1 is a different cancer. M2, M3, M4 are different cancers. M1 does not progress to M2, M3, M4. No, they are just different cancers. Then for acute leukemia chemo, how long is it needed? Well, it's a bit complex. So myeloid leukemia, AML, generally needs about 4 cycles of chemo. Yeah. Lymphoid, ALL, requires 9 to 12, 9 months of intensive, 6 to 9 months of intensive, and 1.5 year of maintenance chemo. So total 2 to 2.5 years for ALL and 4 to 6 months for AML. So 4 to 6 months for AML, 2 to 2.5 years for ALL. Uh, then Sujata SK has asked, sir, only with CBC, when do we suspect leukemia? With CBC, myeloma is difficult. Leukemia, if you see atypical cells or if there are cytopenia, so low hemoglobin, low WBC, low platelet. You remember high risk cytopenia? There are some patients where you have to rule out leukemia. There are no cancer cells seen on the blood sometimes, but the cells are low or cells are high. And you do marrow and the pathologist says, hey, there are cancer cells in the marrow. How low or how high WBC we suspect leukemia? Beyond a normal range. So if your WBC count normal range is 4,000 to 11,000, if it goes below 4,000, you're not sure what is happening, do a marrow. More than 11,000, continuously high, not related to sepsis. If you remember the talk on, high risk cytopenia, how to approach to cytopenia, that kind of tells you when we suspect, we do a marrow to see if we are having a leukemia in this patient. Basit asks, can we differentiate leukemoid reaction with versus leukemia by CBC? To some extent. So leukemoid reaction is a reactive condition, okay? Reaction to an infection. So somebody has sepsis, the WBC counts go to 30,000, 40,000. Okay. and you are seeing this left shift. So you're seeing myelocyte, promyelocyte, etc. And you think this is leukemia reaction, there is sepsis, clinically correlates. Okay. But you see high WBC count with a left shift, with promyelocyte, myelocyte, and the patient is hale and hearty. There is no fever, there is no sepsis. Then you have to suspect leukemia. So your clinical features have to correlate with the CBC, right? Because what looks like leukemia reaction may actually be CML, chronic myeloid leukemia. So clinically, if it is fitting, okay, and when the sepsis comes under control, even the leukemia reaction comes down, WBCs go down, then you don't have to do a marrow, right? So depending on how high it goes clinically, and clinically when your patient recovers, if the WBCs again come down, then it's unlikely to be leukemia. It's probably just a reactive leukemoid reaction. Okay, next question. Okay, I think our, if there are no questions, I would request we stop here. I have to get into another meeting now.
Sure,
You,
sir.
you
Sir, I
have
have
my,
Yeah.
you have my WhatsApp
Ah.
number. Feel free to send queries to me. We will discuss. I've already shared the PPT on the group, and by tomorrow evening, I'll share the exam paper. Yeah. Thank you so
Sure,
much.
sir.
Such a pleasure.
Thank
Bye.
you, sir. Thank you.
Thanks.
Thank you, sir.